Counseling here, she thank you, Professor 𝗙𝗶𝗿 𝘂𝗶𝗃. The counseling here, she will really revolutionize so totally mankane counseling pipare. The symposium conference Finerenone totally pure Java, pure Latt, less sevens avare. Now to Quaro, a call war don't only in a Prusti, Piana, Letuavare. Cardio, kidney, metabolic, the syndrome, Sibori. Or tweet around need I know tweet a genie jarabe. Time general Jimmy aspect lady are two jamu ladies, 2 hours. Two to where Kulu say newer drugs are coming so that we can use this Finerenone very easily. Market them as she la. Zifam Finerenone 𝗙𝗶𝗵 𝗄𝗶𝗃 Lulu Lala, 𝗙𝗵𝗃𝗂𝗃 the series she alone, diabetes, renal diseases, now CKD, alone a Jewish me say 𝗙𝗵𝗃, I only general 𝗙𝗵𝗃𝗂𝗃 no 𝗏𝗏𝗃𝗃 that in Lara Lu she that market them generally clinicians in there she didn't use 𝗥𝗲𝗃 no Dine topics are introduced to Shiba, no 𝗙𝗿𝗃 𝗙𝗿𝗃 Parliament, so general Patamazo 𝗙 or Savio, Pekome, Nitavare. Karangaro, Professor Nwe Symposium conference, chair Lunihama. Dine to do just speaker in the general and Aro to Zifam corpo, not the products, the chairperson, or speakers, or Palau Arte Tales or following Simelu Temare, Rogeno, Professor Nwe 𝗙𝗶𝗿𝗂 or Masoni, Mawe Pima, General Severo, Mumesetova. Counseling Arajan remind Luchemare, heart failure with preserved or mildly reduced ejection fraction, impacting clinical outcomes with non-steroidal MREs. I would like to welcome Professor Nwe for the presentation. Thank you.
Thank you, Professor, for your kind introduction. So, first of all, I would like to thank to the Zifam to the organizer this symposium. So now, it is my great pleasure to sharing my knowledge about the heart failure with the preserved LVEF or mildly reduced LVEF. What is the new drugs? The new drugs is a non-steroidal MRE with the impacting clinical outcomes. What are the impacting clinical outcomes? I don't have the no disclosure. So these are my outline and introduction, burden and mortality across the spectrum of the heart failure, then stages of the CKM syndrome and epidemiological overlap between the heart failure and CKD, key pathophysiological mechanism, challenge in the management of the patient with heart failure with preserved and mildly reduced LVEF, improving clinical outcomes in the heart failure with preserved and mildly reduced LVEF with the non-steroidal MRE. And then I would like to conclude. So first of all, and then heart failure with the reduced LVEF, obviously there is no doubt for the management problem. In the patient with the mildly reduced or preserved LVEF, and then this is a treatment challenge because of the limited targeted therapy. SGLT2 inhibitors show that benefit, but there is a gaps remain in the effective treatment for this population. Steroidal MRA is a spironolactone has demonstrated efficacy in the heart failure with reduced LVEF, but their role in the preserved EF is remain uncertain. So non-steroidal MRA, Finerenone, has shown the benefit in the chronic kidney disease, heart failure with diabetes mellitus. We need more investigation in the broader heart failure population. So if you look at the global prevalence of the heart failure, you can see here the global disease burden of the data. According to the data in the 2021, 56.2 million people have lived with the heart failure. Among them, more than half have the heart failure with preserved LVEF. And then I would like to emphasize here what is according to the PEG heart failure study, the 6-month mortality or readmission is the 56%. However, all these admission and 6-month risk of death and readmission are very similar between the heart failure with reduced LVEF and then preserved LVEF. So you can see here again, the mortality rates in the patient with the reduced heart failure and mildly ranged and then the preserved LVEF are very similar in the most of the heart failure registry. So one of the biggest heart failure registry of the get with the guideline heart failure is a 5-year mortality. You can see here the patient with the hospitalization for the heart failure with the preserved LVEF and reduced LVEF are more or less the same, and then all the clinical outcomes are more or less the same. The proportion of the heart failure with the patient with the reduced and preserved LVEF are nearly equal. So again here, the CKD is very common in the patient with the heart failure. So according to the PET-HF randomized control trial, 25% of the patients admitted to the heart failure patient are associated with the CKD, and increases the risk of death with the patient with the CKDs are very high compared to the patient without CKD. So this is a very important slide because of the stages of the cardiovascular, kidney and metabolic syndrome. And then you can see here the stage 1, 0 to stage 4. Stage 0 to stage 3, those are the initial stage of the heart failure for the CKM syndrome. The stage 3 is the subclinical heart failure associated with the subclinical ASCVD risk. And then stage 4 is the clinical established disease like the stroke, coronary heart disease, and heart failure, peripheral arterial disease, and atrial fibrillation. These are the stage 4. And stage 3 and stage 4 are highly associated with the chronic kidney disease. So again here, what we would like to show you here is a strong epidemiological overlap of the cardiovascular, metabolic, and kidney disorder. You can see here the USHS National Health and Nutrition Evaluation Surveys, and there is an overlapping of the type 2 diabetes, CKD, and cardiovascular disease. And then the other one, and you can see here, the stages of the prevalence of the stages of the CKM syndrome is not that static, not that declining. So what is the overlap between the mechanism of the overlap between the heart failure and CKD? Underlying metabolic disease and MR overactivation are the key pathophysiological mechanisms in both heart failure and CKD. The MR overactivation, the consequences of the MR overactivations are the sodium and fluid retention, inflammation, dysglycemia, adiposity, and hemodynamic factors and cardiovascular hypertrophy, leading to the glomerular injury and fibrosis and cardiac remodeling and fibrosis. This is the key major pathophysiological activation in the patient with the heart failure and CKD. So what are the challenges in the management of the patient with the heart failure with the reduced, preserved, and mildly reduced LVEF? This is the established AHA-ACC guideline. According to the existing guideline is the AHA-ACC guideline. You can see here, there are the stage C. Stage C is the heart failure with reduced LVEF. The green colors are the class 1 recommendation. Very clearly, the stage heart failure with reduced LVEF is the blocking of the RAA system, and sympathetic management of the sympathetic overactivity is that this is a mortality benefit treatment. Or if you look at the stage C, you can see here with the heart failure with mildly reduced and heart failure with preserved LVEF, the only modifiable drug is SGLT2 inhibitors. The rest are the patient have the fluid overload, you need to give the loop diuretics. So if you look at the prevention of the heart failure in stage A and stage B, you can see here that all the SGLT2 inhibitors stay before the heart failure, and the recommendation is for the diabetes. If the patient develops the heart failure, the recommendation is for the both either diabetes or with the heart failure, with or without diabetes. So another thing is that we can see here the stage B here. Stage B here is the patient with the stage B without heart failure. You can see here with the row of the non-steroidal MRA patient, if the patient with the CKD or if the patient with the abnormal UACR abnormality. So this is the indication here for the non-steroidal MRA. So for the heart failure with preserved and mildly reduced LVEF, the rest of the RAA system blockage systems are the class 2B recommendation. So again here, the ESC 2023 guideline compared with the AHA-ACC guideline, you can see here, this is definitely RA system blocking together with the blocking of the sympathetic overactivity is reduce the heart failure readmission and then cardiovascular death with the patient with the reduced LVEF. If the patient with the preserved LVEF, you can see here, the only the drug is SGLT2 inhibitors. So if you look at the evidence for this reason, so that this guideline is, you can see here with the CHAMP Preserve and Paragon heart failure study. CHAMP Preserve for the study with the ARB, with the prototype is 𝗙𝗏, compared with the placebo, there is a negative study. And then also in the Paragon HF study, and then there was the use of the ARNI, we compare with the valsartan in the patient with the preserved LVEF is also negative for the outcome. Again here, for the why the SGLT2 inhibitor in the preserved or mildly reduced LVEF, the EMPEROR, Preserve and Deliver HF study, use of the empagliflozin in the EMPEROR Preserve and then dapagliflozin in the Deliver heart failure study. So this is a significantly improvement in the cardiovascular disease and heart failure hospitalization with the patient with the SGLT2 inhibitors. That is why the guideline is an indication for the SGLT2 inhibitors in the patient with the preserved LVEF. So if we look at the steroidal MRA in the use in the LVEF or preserved LVEF more than 45%, TOPCAT study, the study was mutual. And then that is why there was strong evidence for the steroidal MRA in the patient with the reduced LVEF, but not for the patient with the preserved or mildly reduced LVEF. So this is a negative study or mutual study. So what we need for that, we have the unmet need for the patient with the heart failure with the preserved LVEF or the mildly reduced LVEF. There will be a gap to consider for the modifiable medicine for heart failure with the preserved LVEF. So if we look at the non-steroidal MRA, in the era of the non-steroidal MRA, and they started with the CKD patient with the type 2 diabetes and the 𝗏𝗏-𝗏𝗏 and 𝗏𝗏𝗏𝗏 study. These two studies are patients use of the finerenone in the patient with the type 2 diabetes with the background blockage of the RA system with the kidney CKD stage 4, 3 and 4 in the 𝗏𝗏-𝗏𝗏 and CKD stage 1 to 4 in the 𝗏𝗏-𝗏𝗏. So you can see here there is a significantly benefit of the finerenone in the patient with the type 2 diabetes with the CKD with the background blockage of the RA system. So based on that, and then what is the difference between the steroidal and non-steroidal MRA? So you can see here the steroidal and the non-steroidal MRA and the spironolactone and eplerenone are the steroidal MRA. Non-steroidal is the prototype is the finerenone. So if you look at the potency is very high in the spironolactone and finerenone, and selectively MR receptor blockage is very high in the finerenone and low in the spironolactone and median in the eplerenone. If you look at the metabolites, and then there is no active metabolites in the finerenone and eplerenone and multiple active metabolites in the spironolactone. This pharmacokinetics is very important for the tissue distribution is the higher in the kidney in the both spironolactone and eplerenone, and balance with the kidney and heart is a finerenone. This is a very important pharmacokinetics for the use of the finerenone in the patient with the heart failure, CKD, and type 2 diabetes. And then look at the adverse effect, and then sexual manifestation. Gynecomastia is very common with the spironolactone, and then very rare with the sexual manifestation like the gynecomastia in the eplerenone and finerenone. Hyperkalemia and blood pressure reductions are more or less the same in all three drugs. And finerenone had a little bit low in the hyperkalemia incidence, and then reduction of the blood pressure is a little bit low. So this is what is the finerenone? The benefit in such kind of patient is more selective for the MR receptor than spironolactone and eplerenone, highly potent and more balanced heart and kidney distribution than steroidal MRA, so with the potential safety advantage over the steroidal MRA. So the pharmacokinetics for the finerenone is very important to understand the benefit of the non-steroidal MRE. So what is the evidence for improving clinical outcome in the heart failure with preserved LVEF or mildly reduced with the non-steroidal MRE? So FIND-US is the first study. HF study is the first study for the randomized double-blind placebo-controlled trial investigating the hypothesis of the Finerenone will reduce the cardiovascular death and worsening of the heart failure in the patient with the preserved LVEF. The key inclusion criteria are the very symptomatic heart failure patient with the NYHA 2-4 and LVEF more than 40 with the hospitalized, recently hospitalized or ambulatory patient, elevated natriuretic peptide levels and then underlying structural heart disease, so that this is a confirmed heart failure patient with the LVEF more than 45. So total 6,000 populations are included in this study with the Finerenone use is 10 milligram, 20 milligram, or 20 milligram up titrate to the 40 milligram depending on the eGFR. The primary outcome is cardiovascular death and total heart failure events, hospitalization for urgent visit of the heart failure clinic. And secondary outcomes are the total heart failure events and then KCCQ questionnaire for the heart failure and NYHA class at the 12-month and then renal composite endpoint and all-cause mortality. So this is a baseline characteristic. I would like to emphasize here the 2 points. The 1 point is the LVEF, mean LVEF is 53%. So most of the heart failure patients are about preserved LVEF. And then even though the use of the preserved LVEF with the heart failure, the main drugs for the SGLT2 inhibitor, this study has only 13% and 14% has the SGLT2 inhibitor. So another thing is, important thing is that we would like to emphasize here is the findings of the FIND-US heart failure study, because the study was conducted in the COVID era. So the finding will be a little bit biased. So you can see here, this is a primary endpoint of the FIND-US heart failure study, and the Finerenone significantly reduced the cardiovascular death and total worsening of the heart failure over the median follow-up of 32 months. So this finding, the primary endpoint, positive primary endpoint was driven by the total heart failure event, not by the cardiovascular death. This is a very important findings for the clinical use of the heart failure, Finerenone in the heart failure. So if you look at the deep dive into the FIND-US study with the pre-specified subgroup analysis for the primary outcome, you can see here I would like to emphasize 2 points. 1 point is the patient with the LVEF, not depending on the LVEF, the effect of the Finerenone is the same. So also in the SGLT2 inhibitor, independent of the use of the SGLT2 inhibitor, the efficacy of the Finerenone are the same. So if you look at the safety outcome in this FIND-US study, the Finerenone group has a little bit higher of the creatinine increasing, and then also the potassium hyperkalemia, rising the potassium level, hyperkalemia, and then hyperkalemia leading to the hospitalization, but only 0.5%. So systolic blood pressure reduction in the Finerenone is a little bit higher compared with the placebo. So the safety outcome is very favorable to use of the Finerenone in the heart failure. So this is I would like to show you here, because and then most of the patients and they enrolled in the Finerenone study of the FIND-US study is these more than 50% of the heart failure patients are during admission or previously worsening of the heart failure within 3 months. So this is you can see here the outcome of the cardiovascular death and total heart failure event was significantly. Obviously, we can see here in the heart failure with the less than 7 days or heart failure with more than 7 days to 3 months. More stable patient as the benefit is not clearly. So this is a very important finding. So you can see here, this is here for the patient with after the 3 months stabilized patient is the benefit of the Finerenone is midline. So you see here the benefit is more in the recent heart failure patient, worsening heart failure patient during admission or after the admission for within 7 days to 3 months. So this is another point so that this study can provide us for it is a signal for the absolute treatment benefit with the finerenone in the patient with the heart failure with preserved LVEF or recent heart failure, worsening heart failure need further investigation. So more benefit in the such kind of group in the patient with the worsening heart failure. So this is a pre-specified subgroup analysis with the concomitant use of the SGLT2 inhibitor because this is very important. The SGLT2 inhibitor is the only drugs in the patient with the preserved LVEF. So all the clinical outcome of the combined cardiovascular death and total worsening heart failure, worsening heart failure or CV death all cause mortality. So you can this is a comparison between the two groups, and then the interactive P are not significant. So this indicates the concomitant use of the SGLT2 inhibitor is not influenced on the efficacy of the finerenone. So you can see here for the time for the significant benefit of the finerenone in the patient with the preserved LVEF, you can see that the separation of the two lines started from the 30 days after the initiation of the finerenone and maintained the separation up to 2 years. So the conclusion of the fine art is that finerenone significantly reduced the heart failure event in the patient with the mildly reduced or preserved LVEF. This is different from the steroidal MRA like spironolactone. 𝗏𝗏 study is a negative study. So finerenone may be a valuable addition to such kind of patient, especially in the patient with a high risk for their hospitalization, but its impact on the mortality remain uncertain. The study highlights the need for the further research on the combination therapy, particularly with the SGLT2 inhibitors. So long-term studies are needed to assess the finerenone durability, safety, and potential benefit in the broader spectrum of the heart failure population. So this is a meta-analysis of the use of the MRA, both steroidal and non-steroidal MRA. The meta-analysis of more than 1,400 patients confirmed that the benefit of the MRA in the heart failure patient. However, you can see here the benefit is more with the reduced heart failure patient with the steroidal MRA. The non-steroidal MRA is only the positive study is the fine art study. So this is a fine heart. Because of the previous study of the finerenone in the kidney disease with the type 2 diabetes, and only for the cardiovascular outcome in the fine heart study. So these studies are different for the clinical outcome for the cardiovascular, kidney, and mortality outcome. So fine heart is the aim of the fine heart is a non-steroidal MRA. Finerenone modifies the risk across the cardio, kidney, metabolic spectrum. The question is this one. So you can see here that previously I already talked about the finerenone is a non-steroidal MRA that have been studied in the randomized control trial with the patient with the type 2 diabetes and CKD, separately in the patient with the heart failure. All of these individual studies did not have the power to evaluate the treatment effect on the mortality outcome. So that is why then they have done the fine heart analysis. So you can see the fine heart analysis program, clinical program here. The fine heart is a combination of the fine heart failure study, 𝗏𝗏 and 𝗏𝗏𝗏. So this pooling data is increase the precision to robustly assess the efficacy and safety of the non-steroidal MRA on the important cardio-kidney outcomes, particularly in the patient with the CK and multi-morbidity. So you can see here, this one is a patient with the only one risk factor for baseline CKM status or the only heart failure. The green one is a patient with the heart failure with CKD. Now here the patient with the heart failure with the diabetes mellitus. This is a patient with the CKD and diabetes mellitus with the 3 combination. So these are the combined data, pooling of the data. However, the primary endpoints of the cardiovascular death is including undetermined death or excluding undetermined death is not significantly, statistically not significant. So the secondary endpoint is the all-cause mortality is not significant, and heart failure hospitalization and kidney composite endpoints are very significant for the fine heart analysis. So this is a summary of the pre-specified efficacy of the endpoint. You can see here kidney composite endpoint, heart failure hospitalization, cardiovascular death or hospitalization, and all-cause death or all-cause hospitalization are significant for the favor for the use of the Finerenone in the FINE-HEART study. So the conclusion of the FINE-HEART is the largest analysis of the effect of the non-steroidal MRA, Finerenone, across the CKN spectrum. Although the pool analysis and failure to demonstrate the significant reduction in the cardiovascular death, Finerenone was associated with the significantly lower the any death of any cause, cardiovascular event, and kidney outcomes. There is no new unexpected safety signal were uncovered in the pool analysis in the FINE-HEART pool analysis. So these are the clinical trials with the MRAs for the different categories of the LVEF, reduced LVEF, mildly reduced and preserved LVEF. Some are the completed trials. Completed trial already mentioned for the FINE-HEART and FINE-HEART analysis. And then the important thing is the combination of the SGLT2 inhibitor and Finerenone, and the benefit in the heart failure patient is very important. So these are the many ongoing trials, and then we can get the more information after the completion of these trials. So we can have this one will be the paradigm shift in the management of the heart failure with preserved or mildly reduced LVEF. So summarizing the role of the MRA in the heart failure, MRA have now been definitely proven to improve the outcome in the patient with the reduced heart failure with the steroidal MRA, and mildly reduced and preserved heart failure with the non-steroidal MRA. In the FINE-HEART, and elevated creatinine, hyperkalemia were seen more commonly with the Finerenone and less incidence of the hypokalemia. So MRA increased the serum potassium, but the benefit outweigh the risk in the most patients with the heart failure. So we should not neglect the MRSs in the CKM disease. So I would like to conclude my presentation here. Patients with the heart failure with the mildly reduced or preserved LVEF are present high risk of death and hospitalization, not different from the patient with the reduced LVEF. Underlying metabolic disease and MR overactivation are key pathophysiological mechanisms in the both heart failure and CKD. Among the existing heart failure therapy, particularly in the patient with the for the treatment for the preserved LVEF, SGLT2 inhibitor have demonstrated strong benefit in the such kind of category. So with the treatment of the non-steroidal MRA, Finerenone demonstrated the reduction of the cardiovascular death and worsening of the heart failure event on top of the background heart failure therapy, particularly with the SGLT2 inhibitor. The benefits are, we can see the benefit as early as possible, and then may improve the long-term event-free survival. Currently, US FDA approved for the use of the Finerenone in the patient with the mildly reduced or preserved LVEF. Thank you for your kind attention.